So if we truly want to move toward health equity, we have to stop making assumptions and find good data to see how AAPI health outcomes compare, first externally compared to other major racial groups, but also internally with respect to inter-ethnic differences. But getting good, reliable health data on AAPI outcomes and getting quality disaggregated data by ethnic subgroup is a major, major struggle. When I started my career as a young physician years ago, I looked hard to find AAPI health data, but it was literally non-existent back then. Over the years, it's gotten better, but it's far from ideal. So the level of published rigorous research to date on AAPI health is far from optimal. In fact, a recent study noted that less than 0.2% of the NIH budget was dedicated to AAPI health research. So how should the public health and medical community respond to all this? First, we should denounce AAPI hate, routinely include AAPI issues as part of diversity and equity efforts, and push for better data, particularly disaggregated data. Second, we must understand that Asian Americans and Pacific Islanders, particularly those born overseas, may not feel comfortable navigating the healthcare system, especially if they face barriers with respect to culture or language. Third, clinicians must overcome their own implicit biases and avoid making any assumptions about an AAPI patient. Don't assume anything about their ethnicity, place of birth, languages spoken or not spoken, socioeconomic position, culture, spouse, sexual orientation, or worldview. If you don't know, don't assume, just ask. And in a time like this, acknowledging to patients of Asian American and Pacific Islander background, the difficulty of discrimination compounding the challenges of the pandemic can serve as a way to signal respect and support. And that's what true patient-centered care is all about.